The sky above the port was the color of television tuned to a dead channel. And that pretty much summarizes this episode today, Neuromancer, in that nothing is important, lifting's not important, and as we learned today, Eric, technique is not important.
Yeah, this is the episode of nihilism.
Yeah.
Doesn't matter how we deadlift.
Yeah.
Doesn't matter how we live our lives. It doesn't matter what happens today or tomorrow.
Yeah. Even this.
So welcome to Iron Culture.
Hey. Well, I will say the cult, like everything else doesn't matter, but the cult matters, Eric.
Oh, there's the one true thing that you need to know and believe, and that's anything that we say.
Oh yeah. It's someone said, it's funny. I've actually read this a few times that they have a hard time differentiating from either of us when we talk. And I know we both have very robust voices. Some might say radio voices, but we met our match in this episode.
Oh man. So, I mean, I might mention it at least once, twice, or like 45 times in the episode.
You made him uncomfortable.
If you couldn't tell, I was a little enamored with Quinn Henoch. I got over it. My wife and I are in counseling. I've been instituting some daily rituals to make sure that I am attracted to her and don't imagine her as a weightlifting
god,
caramel colored god with a wispy mustache and a deep voice. And that's just an unemotional description of him. That's not anything beyond that. Omar, can you save me here and talk about pain science?
No,
or something?
it's real impartial in your description. I think no one could take that out of context or interpret it any other way other than Quinn Henoch has a baritone voice, and forget what he says, which makes a lot of sense. It's how he says it, and that's why we speak about a lot of things. My ears perked up at one point where we had Nick on, we had Jordan of Barbell Medicine, we had Quinn Henoch of Clinical Athlete. We talk about injury, pain, rehab. What is pain? What is the current state of pain science? We talk a little bit about prehab, what that even means. We talk about injury prevention, or really we should say injury reduction. And then we all perked our ears up extra when Jordan Feigenbaum said, yeah, I'm just a technique nihilist. And I'm like, oh, you like nihilism? I love Russian literature that talks about we could get all in depth. And he's like, well, I don't actually mean that it's absolutely useless and meaningless. I'm like, well, you're not a true nihilist. You're just a pretender. But,
Yeah. How dare you backpedal to something that's actually like works as being a living human who hasn't taken his own life. But no, we had a really cool discussion. I as a non-expert in the area, so here's something that happens to me all the time. And it happens anytime, I think, to any fitness professional who has a decent online presence, is you get asked questions about, hey, my blank hurts when I do X, what should I do? And the responsible advice is to always tell them to immediately seek surgery without consulting anyone except a surgeon. And when they don't tell you not to get surgery, just get it regardless, and also take a lot of drugs. That's always responsible advice. No, I'm kidding. The responsible advice is to stay within your scope of practice. So I acknowledge that, hey, I have a PhD, which out of this, panel of DPTs and MDs is ranked about, 3rd to 8th, which is impressive when you finish 8th out of 3 possible places. But anyway, I'm just a philosopher of lifting, and we had some actual experts with clinical experience. So I tentatively challenged Dr. Feigenbaum's position, and I feel like we had a really good discussion that came out of it. And really also good inputs from Nick Licameli and Quinn Henoch, who are both, doctors of physical therapy. And it was just a real treat to have them all on because they all have such robust, extensive experience with slightly different takes on it. Like I said, we got 2 DPTs, 1 MD. Nick has worked with a lot of Gen Pop and now through 3DMJ, a lot of bodybuilders. Quinn Henoch has worked with a ton of weightlifters. And like he'll tell you, he basically his clinic is a huge weightlifting gym. And then I know Jordan has been doing a lot of work with barbell-based athletes as well. And he has a history working in like the starting strength community and now doing his own thing. So we just have a lot of people coming from a lot of angles who've all helped lifters of various, threads. So hopefully this gives some really good insight and perspective onto some, I would say, areas that the quote-unquote kind of evidence-based focus community has probably been a little behind on compared to, say, nutrition or training.
Sure, absolutely. And I just want to say, how dare you, Eric, for bringing up starting strength when you know Jordan has PTSD over what happened. But, I mean, Jordan, we're here for you, man. I just don't know why you would say such a thing.
Well, I think the fact that you told the world that he has PTSD is creating an expectancy effect, and that's basically a nocebo. So now you've made that real, and we know that pain lies, whether it's psychological or physiological. So next time you feel bad about something, just don't.
Yeah, just don't feel bad about anything at all. And that, my friends, is nihilism. And that is the real subject, the core underpinnings of what we talk about. And we're all united, even though it doesn't matter, in that nothingness. So just enjoy. Well, I was going to say enjoy this episode, but it doesn't.
Just be. And unless you don't want to, then it doesn't matter.
Yeah.
All right. See you next time on Iron Culture.
Hopefully. I shouldn't say hopefully, because that's an expectation.
I don't hope.
Yeah.
Yeah. So anyway, we're going to talk about injury. It doesn't matter if you get hurt or not, and we don't know what causes it. Pain is a lie, and enjoy this panel.
Yeah, that's accurate. Look, everyone was coordinated at the same time. I want to give the scene right here of what's going on. You've heard of 3 guys, 4 guys, 5 guys burgers. What about 5 hot guy babes all discussing one thing at the same time? Nickelback. Which brings us to today's topic. We have experts here: Jordan Feigenbaum, Quinn Henoch, Nick, Eric, myself. We just want to talk about our favorite song and by them, and it's probably it's going to be controversial. And Eric said, don't say anything controversial, Omar, please, when we do this episode. But I'm going to say it. It's got to be Rockstar.
Is that's your favorite one?
To self-mutilate? Yeah. 2? Yeah. Yeah.
Like Photograph to me, honestly, was the best off their self-titled album, and I just feel like whenever I hear that song, it makes me want to hurt myself. And I think it just, for my money, it doesn't get much better than that. Yeah. Just there's a lot of vowels in that verse, you know. It's all vowel sounds, which is
real guttural, you know. If we're gonna do, Jordan, the autoerotic asphyxiation, you got to do it right. You need the right tune. So we're blessed here today. We're here to talk about rehab, injury, a lot of different things. Before we go on, Coach, is it okay if I just try and summarize each individual's position before we really expand this discussion? Is that okay?
I always think the best way to do it is to not ask the guest their position, but to tell them in the audience what it is. I think it's just more efficient. So,
Coach,
Omar, go for it.
Thanks, Coach. So, Jordan, your position when it comes to pain science, injury, and rehab would essentially be that pain don't hurt much. Dalton from Roadhouse. Is that accurate? Just a yes or no before we go on.
It's more nuanced.
Okay. So that's a yeah. Cool. Okay. Quinn, you, obviously, I've seen your videos. I've read some of your articles. It's more like love is a battlefield is how you describe pain.
Nailed it.
Thank you. Okay. Yeah. Quinn, thank you. And finally, Nick, it would be the NWA song, Fuck the Police, is what I heard, is your position just when it comes to pain, lifting, everything else, yeah?
Yeah, I think it was actually Mark Twain who originally said that.
Yeah, no, it's apocryphal, but I heard it is true. So you learn something new every day. Guys, hey, Coach, you want to close out this episode? Because we just did it.
Yeah, this has been an excellent episode of Iron Culture. I think you learned everything you need to know about injury prevention and management. So I just want to thank doctors Nick Licameli, Jordan Feigenbaum, and Quinn Henoch, and we'll see you next time.
Funny.
Okay, so now to the actual podcast. Yeah, we have to clap again now to start off. That's right.
Yeah.
No, but in all seriousness, or at least a little more seriousness than Omar set the bar at, which is basically a bar laying on the ground. We've got many doctors in the house. We have Dr. Nick Licameli, our Team 3D Muscle Journey Injury Management Specialist and Recovery Prevention, all the words that I can never remember his actual title. But awesome dude, pro natural bodybuilder, and also a doctor of physical therapy. Nick, tell us a little bit about yourself, introduce yourself, and we'll go around the in clockwise order on my screen, which no one else can see.
Yeah, so I'm glad I'm going first so I can kind of thank everyone before anyone gets any humble comments in here, but I just want to thank you guys all because you've all played a huge role in who I am today, and I wouldn't be here, literally would not be here if it wasn't for all you guys and all the the content you put out. And so I want to just thank you guys, and it really shows that you don't ever exist alone, right? You're always learning from different people, and I think that's kind of where this conversation may go. Being open-minded and just trying to absorb as much as you can and as many different sources as possible. But about myself, I live in New Jersey. I'm a director of an outpatient orthopedic physical therapy office. Like Eric said, I'm the injury reduction and management specialist for 3DMJ, which is such an honor to even say. So basically, it's a dream position. I work with 3DMJ athletes. I work with other athletes that reach out to me, and we do consults online. And I'm kind of diving more into the telehealth realm of our profession as we speak. So it's an interesting journey trying to dive in. And I'm married, expecting a baby any day now. So other than that,
minor details,
So
Awesome, man.
if I get the call that my wife's in labor, I'll just head out and catch you guys later.
Biopsychosocial model, manual therapy is not that important, and go hard or go home. See you later.
And natural bodybuilding is one true discipline. Peace.
Yep. And out. Awesome. Everything you said, greatly appreciate it. You're an asset to the team, and glad to have you on the culture. Dr. Jordan Feigenbaum, we just recently met in person at the European Powerlifting Conference. We were in London. I was hungry. You were talking about like concepts and long like biopsychosocial. You're saying fancy words that just made me angry and also hungry, but everything makes me hungry at the time. So no, it was really an honor to meet you. I thought you did a fantastic job talking on both the panels and in your presentation, and you've been kind of leading the charge with barbell medicine. And providing a lot of unique resources and perspectives that I think have been much needed. So tell us a little more about yourself.
Sure. Thank you guys for having me. Eric, it was a pleasure to meet you. I'm sorry that I made you hungry and for anything that you may have said while hungry. My name is Jordan Feigenbaum. I started barbell medicine in 2012 when I entered medical school. I graduated medical school, went on a residency at UCLA in family medicine, and then barbell medicine has grown significantly since its first inception. It was just me, and now there's a lot more moving parts, including our pain and rehab division that's headed up by Dr. Derek Miles and Michael Ray. Also, Dr. Austin Baraki. We're all just kind of trying to put out high quality content and help move the needle forward. So with respect to injury risk reduction, particularly as it pertains to resistance training, I think our stance on this is born out of the current evidence that we have, scientific evidence, and then we all have experience in both coaching and lifting. So that's, we're trying to bring both worlds together, aka the bringing modern medicine to strength conditioning and strength conditioning to modern medicine. So that's our tagline, but it is true in a way. We don't just want to be eggheads about this thing and say, yeah, well, here's what the literature says, do with it what you will. We want to apply that practically, and any time or any way that we can make that more accessible to the general population or other practitioners, that's a win for us. So I'm really looking forward to today's panel. And again, thank you guys for having me on.
Absolutely, man. And we appreciate what you do. And then last but certainly not least, Quinn Henoch, Dr. Quinn Henoch, DPT, of clinical athlete, the gentleman of the group with weightlifting, doing the things that are most impressive. And by the way, freshly manicured beard, well-fitting shirt. And look at that whiteboard in the background. I think I'm already the most impressed with you, so I'm going to say whatever you say is probably right. And which means that my own colleague at 3DMJ, I'm already just taking a dump on. That's how good your facial hair is. So if you could tell us more about you and your manliness,
and how we could look like you.
Yeah, just in general, tell us more about how to be like Quinn.
Well, so that's an 8-foot whiteboard there, and
that's impressive.
Because sometimes I'll write on the very far left side, and just because I can, walk 8 feet all the way to the right side, make a counterpoint to myself. There's some powerful things that happen in this office. And my barber is a 3-minute walk down the road, so that's how you get there. I appreciate the intro, guys, and I appreciate being here. It's an honor, and how I can describe how uncomfortable I feel being called doctor when there's an actual doctor on the panel in Jordan.
Jordan.
Doctor.
I thought you meant
just
the PhD.
Yeah. The real doctor.
I thought you were talking about me.
The nerdy doctor. So I am in Southern California. I'm a physical therapist in Orange County, and I have an office inside of a weightlifting gym. It's SoCal Weightlifting is the gym, and it's unlike any other weightlifting gym I've seen. I think we've got over 115 only weightlifting members, so people that come in the door say, hey, I want to do the snatch and clean and jerk. That many, and I think the biggest weightlifting crew that I've seen in any gym in the area, anywhere that I've traveled. And my office is sitting right in there, which is pretty cool. So I've got enough space for my table and a couple other things, and I open the door and there's a playground for me. And it's definitely the environment that I always wanted to be in, and I'm really grateful for that. The majority of the people that I see are in the barbell world. Most of them are weightlifters, some powerlifters, some CrossFitters come trickling in. Everybody else is an athlete in the way that I would define that they have athletic goals in some capacity. Whether or not they're any good at their physical endeavor or their goal activity is another story, but most of the people that I see, if not all of them, have some type of physical goal to get back to. So it's the population I want to see, it's the setting I want to be in, so I'm very, very lucky.
Awesome. Well, we're quite privileged to have you all here, and I also just want to ask: do you say it's a bass or baritone that is your manly voice? I'm not sure. It's on the border, but man, yeah. You definitely
you're one-upping myself and Eric.
Yeah,
talking to me.
Oh yeah.
Well, come on.
Yeah, the hunk in the corner. Yeah, you.
Who me? I don't know what you're talking about.
There's a setting on Skype that I must have worked there. Perfect.
Pitches your voice down a few octaves.
It's amazing. Yeah, I think the only thing that we've learned from that is that I have a massive man crush on Quinn. So Omar, I'm going to let you take the reins from here before I just embarrass myself further.
Well, I've also fallen under swoon, but it's for another individual, and that's Jordan. When we met in person, it was, as I said, the sexual tension. When you gather together 5 hot guy babes, it's inevitably going to happen. I think to open up this discussion, however, and open up a few things, I'm surprised, Quinn, you went for a 3-minute walk and not for a 10-minute walk, which has become popular recently. But, 3-minute walk to your barber, be that as it may. I wanted to ask you guys about the current state of rehab, pain science, lifting in general, where it comes to individuals that experience things where they want to try and quantify it. Where do we stand? Where does the literature stand? Where does it stand when it comes to being a practitioner? What do we know so far? Because, you go online. I'd put forth that maybe when it comes to pain science or injury rehab, some of the categories maybe fall under the realm of a little bit of pseudoscience, where there's still some evidence coming out. And so we're right on the cusp, we're on the precipice of something. When we had Dr. Gabrielle Fundero on talking about gut health, something similar where when you're just on that edge, there's some misinformation. For the viewers out there, maybe it would be helpful for each individual to explain either their position or their current knowledge when it comes to where we stand, when it comes to lifting, injury, rehab, pain, anything, things that they may have heard that they might be mistaken, things that need to be clarified, anything that you'd want to say as your opening statement.
Yeah, how do we differentiate between pseudoscience and actual useful practice? I think is a good way to position that. And let's start with Nick.
Yeah, so I think one of the things that I kind of wrestle with is as I kind of get further and further in my career is whenever I think something for certain, I always stop and say, wait a minute now. We all know that feeling of thinking something 100% and then it being proven wrong, or we learn differently and things change. So I've kind of become comfortable with not speaking in definites. I think out of physical therapy school, at least in my experience, I had a great physical therapy program, and they prepared me well to pass my boards. I think we're trained almost like mechanics, to kind of approach the body as, finding impairments, finding what's wrong, finding what's tight, finding what's weak. And we're given an arsenal of different tests and techniques and manual treatment and modalities. And we go out there ready to save the world and put bands on everyone's knees to squat. And I think it's tough, because then you get exposed to different research and different resources, and then it questions all of what you believe in. So then it's easy to swing the other way, right? And then think, oh, no, none of that stuff matters. So I think it really depends on like the situation and the patient in front of you. So I guess what we know now is that it's not pain and injury prevention is very complex, very, very complex. And we're starting to scratch the surface, I think, on a better approach to it, more multifactorial, less structural diagnosis and things like that. I mean, I'm sure you guys have been through the same process, Quinn, coming out of physical therapy school. I know it's kind of what I've heard, on different podcasts and things that you put out. Is that been your experience as well?
Yeah. And way to start us off with an easy question, Omar.
I just want to go
what's the current state on the world?
I just want to go into the 8th circle of hell. This is Dante's Inferno, after all.
I appreciate you. So agree with what Nick said regarding uncertainty. Pain and training, these things, the lines get blurred. If we take out the legality of all of these things and we just say, what are the principles that are governing the human that's in front of us? Pain is this phenomenon that's multifactorial and can certainly confound things. But I think what we can observe is that training, rehab, this experience of pain is emergent, it's nonlinear, and it's dynamic. And we can define emergent as self-organizing to some degree. So, in motor control, we could give a simple example of self-organization as you walk on a treadmill without saying a word, you just speed it up, and eventually you break out into a trot. And if you don't have a trot pattern, you fall on your face. But that trot is an emergent pattern. Well, we can see the same things when it comes to rehab, and the experience of pain. So as healthcare providers and as coaches, we are kind of tour guides. We're course correcting, but in a way that hopefully allows the individual to self-organize and to reframe their situation somewhat on their own. This whole process is nonlinear. I think this is the point that people get hung up on, especially the athlete themselves, that we can say, hey, trust the process. There's going to be some ups and downs. Yeah. But the reality of that is very real. And when an athlete has a setback and we remind them that this is that nonlinear process, we can kind of equate it to training. We know that we're not going to just add 5 pounds to the bar every single training session forever. It's not going to be once we get over 3 sets of 5 and we're at 5 sets of 5, well, where do we go from there? I can't just keep adding 5 pounds to the bar. Well, pain is certainly in that same breath. It's nonlinear. I think if you step way back, there are still patterns, but the closer that you dive in, the closer that you look at an individual, these things become a lot more seemingly chaotic. And these things are dynamic. And I think this is the big piece. Dynamic means there are multiple subsystems that are interacting. And the outcome is a summation of those factors. And any one factor is relatively meaningless if you're not looking at how those individual factors interact. So we've got the individual, we've got their goals or the tasks, and the environment, and all of these things interrelate. Pain is no different. The perception environment coupling, that is kind of this person that's embedded in their environment. What Nick was getting at is we can't pull out some type of biological or solely mechanical mechanism to explain such a complex dynamic phenomenon that is the subjective experience of pain. If we were literally robots, if we were a door with a rusty hinge, perhaps it could be explained that way a little bit more accurately. But because we're humans, because you can't separate us from the environment, we're not a brain in a vat. We're somebody who's constantly acting with the environment, and the perception of pain is heavily shaped by that environment, as well as what's happening internally. So obviously biology matters, but that's kind of where we are right now. It's not getting any easier. So Omar, to your question of what is the state of rehab and pain, it's more complicated than it was before, I think, because we're starting to understand how complex these things actually are. And then, as Jordan said in the beginning, the real skill is being able to take these complex topics, distill them down into something actionable that we can use in the clinic and use in the gym. And I think that's where the good coaches and the skilled clinicians really shine. But I don't have an answer to your question where we stand. I'd like to see this conversation emerge a little bit, and we'll see what comes out of it. But that's kind of where I am with things.
Yeah, I think that's actually a really good point, Quinn, when you talk about it becoming more complicated. I mean, if we just look at this historically, in the 60s, 70s, prior or at that time in the medical community, injuries and the pain experience were revolved around what's known as the biomedical model, which effectively is a structure function model, meaning that if you have pain, all right, from a certain area, it's coming from tissue damage or something mechanically or anatomically wrong in that area. And then in 1977, Dr. Engel, who's basically the father of the biopsychosocial model, came up with this new model, this new way to reframe things, mainly because the biomedical model was insufficient and inadequate at describing people's pain experiences, meaning that people could have pain when there was no evidence of tissue damage that you could diagnose in any sort of way via imaging or via any sort of clinical exam. And in addition, people with evidence of tissue damage based on imaging or clinical exam might not have pain. So it was more complex than that. So that was like the first rung on the ladder towards increased complexity. And since then, so since the 70s, we've layered on additional nuance to sort of complicate and basically expand how we actually think about what is actually triggering pain from certain sort of insults to the body or certain conditions, certain environmental stimuli. So, and even to make this more complicated, we didn't actually have a definition on the books for what an injury actually was until 2006 when it comes to sports and athletics. The first World Congress on Sports Injury, which was led by FIFA in 2006, was the first time we actually kind of gathered together, rallied the troops and said, here's what an injury is in sport. Before that, it was just kind of like, oh, you have pain, you must be injured. Right. But the reciprocal wasn't always true. Like even if you had quote unquote tissue damage and maybe an abnormal clinical finding on exam, but you had no dysfunction or pain, was that an injury? Like no one had a good answer for that where there was no definition. And so, it seems to me, if you're asking what's the current state of the research and then how does that transfer over to sort of clinical management, things have become much more complicated, as Quinn alluded to. And then we also, I think the pendulum is also swung from this idea that there is this structure function relationship that always correlates, meaning that there's some damage to the structure and that's what's causing the dysfunction. That's what's causing the pain experience. To now it's just more there. Again, there are other things that are involved. So to use a practical example, low back pain. Previously, it was always thought that the reason why someone would have this non-specific low back pain was that there was some nerve that was either being irritated, compressed or otherwise damaged, causing and caused a signal, giving a nociceptive signal, which was inappropriately referred to in many textbooks for many years as a pain signal. But really what this signal is just a neutral stimuli. It's just information that the brain receives. The brain's receiving that information, and we now think that based on psychological states and environmental stimuli and the context in which the person is interacting with their environment, you can get a pain experience, or maybe not, from that actual neural information. So we're layering in complexity. What's really interesting is that, again, if you'd gone to the doctor in the 70s or 80s and you say, my back hurts, they'd probably explain it to, there's probably a nerve that's, injured or being compressed or being damaged, and that's causing the signal. And so, you need to fix that. Right. And so it builds this narrative on which you're damaged. That damage must, be fixed in order to, for you to have a resolution of symptoms. And now I think people who are on the cusp of the pain science information are like, that's not a useful narrative to build, because not only is it untrue, but it also hamstrings the person who's experiencing the pain. So effectively, they're like, well, how do I get the nerve to be, not being sending this information to my brain anymore? Like, do I have to have surgery? Do I have to go through all these different treatment modalities in order to get better? So I think people on the cusp are like, okay, we need to move away from it, not only building that narrative, when we're explaining to people what we think is happening, from both just like an educational standpoint, but also from a management standpoint. And then the final part to this is that you have people who are not familiar with the research at all, okay, but they are in the exercise science space, and they've almost reverted back to this structure function kind of model, this biomedical model of pain. And it's indicated with all this rehab stuff, where it's like you have to do these certain warm-up drills, these certain mobility drills, these certain stretching protocols, these certain, things in order to prevent an injury or reduce the risk of an injury, because you have to get the structure prepared for the movement. You have to get the structure healthy for the movement. You hear people, and here's the red flag giveaway. When people talk about nebulous, completely made up farcical concepts like shoulder health or low back health, or, and it's like, what does that even mean? To give you an example, when you look at the MRIs of baseball pitchers who are actually active in the MLB, and you do an MRI on their throwing shoulders, you see a very, very high prevalence of MRI detected abnormalities in asymptomatic individuals, meaning that they have diagnosable, quote unquote, tissue damage or structural damage, but no deficits, right? And so if you are of the opinion like, well, no, you need to do this band distracted mobilization and like these band pull aparts, and then like, roll yourself on a lacrosse ball and like have somebody dig into your shoulder with a jigsaw, not like the machine, but like the mobility thing, in order to prepare the tissue or get the tissue, quote unquote, healthy again. Not only is it untrue, but it builds this narrative of like, you're damaged, you're like a car or a rusty, an old door who needs to be oiled and all this other stuff, and you're fragile. Whereas the pain experience and the injury incidents, like having an injury, is much more complicated than that, and the people are unlikely to be well served by building that sort of narrative. So again, to kind of wrap up this opening statement, I've been continually impressed with people who are on the cusp of this research and who are vocal in this community, because they're really focused on narratives and how people talk about this in language and how we address the problem. What I've been less impressed with has been kind of the old guard, is what I'm going to refer to them as. Just people who are not familiar with this at all, and they're like, if you have knee pain, it's because your squat technique is bad, or because you didn't mobilize before you squatted, or if you have knee pain, you should mobilize before you squat. Whatever that means, in order to get rid of the knee pain. They're just kind of reverted to that biomedical model, and it's frustrating because when you try to bring science to that discussion, they're just nope. This is what I see in my clinical practice, my uncontrolled observations, and my recall bias notwithstanding. This is how it is, and I don't care what you eggheads have to say about the science. This is how I do it. And those people, their clients, the people who subscribe to their content, who follow them on Instagram, who see this stuff, are ultimately being potentially harmed by that narrative.
Yeah,
I really. Sorry, go ahead, Nick.
I was going to say, I think one of the reasons why we're all so passionate about this is because I think we've all been there, right? We've all been that. Well, me anyway. I've been that person who foam rolled for 20 minutes before I trained, because if I didn't, I would be at risk for injury. And it's a very similar journey that I went through in physical therapy that I did in bodybuilding. Just like foam rolling before you train, or slamming that post-workout shake as soon as you finish up your workout. We've all been there, right? We've all made those assumptions. We've all learned from what we thought were credible sources using the most current research, and I never questioned it, right? So with bodybuilding, I did a lot of things back in the day that I look back at now and I realize, like, wow, I didn't have to run to the bathroom and eat that cottage cheese because it was 2.5 hours after my last meal. Just like now I look at my practice and I see things that have changed my practice. When someone comes in with pain, I don't automatically assess their posture or assess their squat technique. I'm asking more questions about their life, about what led up to this point. And I think because we've been there, I think that's why we're so passionate. I don't want to ever make it sound like anyone who thinks those things is stupid, and I'm not saying that anyone mentioned or inferred that, but I don't want it to come across like we know so much, because I was there, right?
Sure.
We were all there, and we all learn from our mistakes. And I think education is a huge part of this. And I like to use a lot of analogies. One of my favorite ones is, and like Jordan was saying, that the pain response doesn't usually or doesn't have to correlate to tissue damage. Is like a car alarm, right? So if someone bumps up against your car, the alarm's going to go off with the same intensity as it will as if someone was breaking into it. So it's these inconsistencies between the tissue damage and the pain response. Another one of my favorite analogies that I like to use, and it kind of goes with the concept of graded exposure, where instead of looking at someone and trying to fix some kind of structure or pathology on them, we should kind of take a step back and look more globally at what are their goals, what's the movement they're trying to get back to, what's the painful movement, where are they getting this pain, and why. So for me, I treat a lot of general population patients and older patients, younger patients, and it all boils down to they have some movement that's painful, let's say a squat, like a low back pain with the squat, say. It could be a barbell athlete, or it could be a senior citizen who's trying to stand up from a chair and they have back pain when they're doing it. So is there something structurally wrong with their spine? Maybe not. Maybe it's just we have to gradually expose them to that painful range of motion. And maybe that has to do with, having a supported sit to stand. So have them hold on to like a TRX strap and have them kind of go down. Or maybe it's you build the chair up with some cushions, right, to make it a more shallow squat. And then you kind of groove that movement, you groove that squat pattern. And then their body kind of gets used to, okay, I can go down into this position. I can go through this movement, and I don't have to set that alarm off, right? I don't have to send that pain response. And then gradually, as you load in that shortened range of motion, then you take a cushion out, and then you try to go down a little bit further. And the idea is that you're exposing the body right to like that edge of discomfort. And then the idea is that threshold where I get higher and higher. Another analogy I love to use, Quinn, I heard it first on a clinical athlete webinar. I think it may have been originally from Greg Lehman, but the pirate, the captain on the ship. So there's a captain on the ship, and he sees the first mate sees lights in the distance, and he tells the captain, there's we see lights out there, and the captain has to decide now what the plan of action is. And his response is going to depend on a lot of things. If he sailed those waters before, if he's familiar with it, if he knows there's no pirates and there's no danger, he may just say, everything's okay. It's okay. Let's just stay the course and keep rolling. But if he's taking in thoughts from his environment, maybe his uncle or his someone in his community or a friend gave him some kind of false narrative about pirates in the waters. Maybe he just watched a movie about pirates. Now that changes everything, right? Now the first mate comes, or maybe he was hurt in the past, right? Maybe he was attacked by pirates in the past. So now the first mate says, hey, there are lights in the distance. Now maybe the captain, says, all hands on deck, everyone get ready for battle. Everyone gets ready on the ship to fight for their lives. And it turns out it's just a lighthouse, right? So it's the same stimulus, right? There's just a light in the distance, but a completely different response. And the way to help that would be to gradually expose the captain to that stimulus, right? So maybe you don't get quite as close to the light, but you keep your distance and you let him see the light. And maybe he sends half the guys to the cannons just in case. But then you gradually expose him to that and let him realize nothing bad is going to happen. It's safe. It's just a lighthouse. And then before you know it, over time, as you kind of groove that movement and let him be gradually exposed to that, pretty soon he will be near that lighthouse and he won't have that response. So it's kind of an oversimplification, but that's one of the ways I like to explain it to my patients. And I would say maybe they pay attention to the first 5 seconds and then they stop paying attention. But it even helps in my own mind to kind of get a plan ready. And then, like Quinn said in the beginning, there's going to be ups and downs, right? So it's never going to be, we're going to gradually expose you to this movement and you're going to have less pain every single time you come in. I make it clear that there's going to be ups and downs. You may get a bad night's sleep. You may help your friend move, or you may, I don't know, there are, plenty of different things that could happen. So I say be ready for some ups and downs. You're going to feel great some days, and you're going to feel not so great other days. But on those days that you don't feel that great, I don't want you to think that you're broken or we did something wrong or you did something wrong. It's just a normal healing process. And I think that if I was a patient anyway, I would like that. I would like to know that it would comfort me. It would know that everything's okay. It's to be expected. And then I would get that reassurance when I came in. If I'm nervous or anxious, then I can say, remember in the beginning when we said we're going to have those ups and downs? This is one of those times. Like, let's just stay the course. We'll modify the program a little bit today. We'll keep loading that tissue right to that edge of discomfort, even though it may be a little bit different today. And we'll get right back to where we were before. And that's kind of, the approach that I've taken. But where I've come from was very different when I first started treating. I thought my hands were magical, right? And you could palpate this muscle and mobilize this joint and hallelujah, in a couple seconds the patient has no more pain when they raise their arm up, and I'm a magician, right? And I think that like Jordan said, kind of gives the patient a dependent mindset, right? They're dependent on my hands. They're dependent on something that I have. They have to keep coming back to me to get that crack or to get that release. And
that crack.
Mm-hmm.
Easy. And the feds are listening.
And as much as it may seem like that's cool, but it's not the message that we want to send. That's not what I want. I don't want my patients coming to me and saying, "Oh, my back's hurting. I need you to just crack me." That's not what I want, right? I want them to feel that back pain when they're home, and then I want them to say, "Okay, Nick gave me these tools. I know my back isn't broken. I know that there's nothing structurally wrong. It's just a flare-up, and these are the tools and stretches that he told me to do to kind of calm down that, in the short term, and everything's going to be okay." I think that's a lot more empowering than the message that I used to send anyway.
As an outsider looking in, as someone who has been in the science communication space, in the kind of the exercise world, which is, I would say, dominated by probably the nutrition and physiology, and then like programming and resistance training, at least in the barbell world. That's kind of like the locus of where the evidence-based kind of growth has occurred. Stuff like, gut health, injury prevention, and a few other fields, I think they're happening on a slightly slower timeline, at least in our community. So as an outsider looking in, I definitely see where you guys are at. It reminds me of when we were pushing back in the nutrition world against like the clean eating. And we were trying to really emphasize, hey, like we need to understand energy balance, and we need to understand why these foods might be useful. But hey, here's what we need to focus on. And it became kind of this war, like Jordan was saying, with the old guard, where, the narrative was, well, that's not what IFBB pros do. so you guys are dumb. And then it started to create these camps and divisions. And then you had to kind of be the iconoclast and push back and point out times where we could break the supposed rules and 10 commandments that existed to prove the point. But I think one of the unfortunate consequences of that is that we also lost a lot of the observational wisdom that might have come from that community. And now it's taken us years later to come back and go, oh, so maybe there is something towards eating these foods that were on that list and building meal plans around that because it's more satiating and I have better energy and maybe I don't have a vitamin deficiency, et cetera. Or maybe that's like they were wrong about why it worked. Like the mechanism was totally off, but what they did actually might have made a little sense. And it's interesting how like clearly the biomedical model of pain is limited, but bio is still in the biopsychosocial model. And one thing I have seen almost as kind of this reactionary response to some of these ideas that you guys are putting out there is that, and I don't think this is any of you, but sometimes people who hear that, their idea is, okay, well, we need to jettison the ideas of good technique, or we need to jettison the ideas of pain ever being indicative of tissue damage, or we just ignore pain and work, with tissue damage, and we ignore pain and just train through it, which is kind of what strength athletes did anyway before. But
I don't know any good strength athlete that doesn't train through the pain because it's just weakness leaving the body, bro.
Absolutely humming. Yeah, so I guess where I want to take this, and it might be a slightly different direction, is how do we ensure that we don't potentially lose the arguably overly reductionist and limited things that might have come out of the positive experiences of the past while incorporating this new knowledge? And because that's something I see. It's mostly people who have potentially read some of the work or the messages you guys have got and then gone like, oh, so pain tells you nothing. And I'm like, oh, I don't know. It sounds like pain tells you more than it used to. It's not indicative of tissue damage, but it might tell you about your overall state of where you're training, and especially in a self-aware athlete, man, like pain might even be more useful as it's a more global sensor. Anyway, I think that would be an interesting direction to take this.
Yeah, no, that is interesting, especially, I mean, when you talk about, how long it's taken to kind of get the biopsychosocial model like into the brains of most practitioners. I mean, the average time for medical change to come about from translational research is about 17 years. So we're a little late on Engel's work. He's 1977, and now it's 2019, and so we're slowly starting to turn the tide. One interesting anecdote is I got my master's in 2010 in anatomy and physiology, and one of our course was heavy in neuroanatomy because the program director was a neuroanatomist, so that was his thing. He's like, I think this is important, so you guys are going to think this is important. And I remember memorizing in excruciating detail all these pain pathways, like the C fibers and the dorsal root ganglion, and like where that synapse is and where in the brain, like the whole pathway. Like I had it all drawn out, like I was like a mini Frank Netter. I was like, this is it. This is how pain happens. All right, okay. So then fast forward to medical school, and during our neuroanatomy course in medical school, the guy, our professor, was way ahead of his time, and we were honestly too dumb for anything that he was telling us. But he went over the biopsychosocial model and also like all these like pain sort of correlates and how it wasn't always related to this biological cause. But we were too stupid to actually interpret it. Austin and I talk about this often. We're like, we were exposed to it, but we missed the boat. And I think a lot of that was because there wasn't much practical takeaway. It wasn't like, so because it's not always related to this big biological cause, right? There might be and there's going to be differences in which how much biological quote unquote damage or issues causes a pain experience in an individual based on psychological and social factors and their environment, etc. Here's what you should do. Here's how you should change management, right? So that never really happened. So it was really hard to like piece that together. But in any event, it was just interesting how like there was no mention of that at all during my master's, but then during my medical program, like we were exposed to it. We're just too stupid to we didn't have a mental model for it. I think you're right that since this stuff has been emerging, and particularly in people who may not actually manage injuries and rehab in a wide swath of population, there has been this kind of movement to jettison any biological sort of cause as the source or one of the main contributors to someone's pain experience. The way I like to think about this and conceptualize it, explain it to people, make it more accessible, is like the pain experience. You can kind of break this down into like a pie chart, right? And so you're going to have some portion that's caused by biological factors, some portion that is related to psychological factors, some portion that's related to social factors. That's all integrated, and experienced through the lens of someone's environment, right? And then the output is going to be unique to that individual. If you have somebody, for instance, is in a tragic car accident, they have a compound fracture of their femur, right? There's certainly a larger biological cause to that person's pain experience, but the context is dependent, right? If they need to escape from the car because it's on fire, they may not be aware that their leg is actually broken, right? Or that they've dislocated their shoulder until they're in a safer place, and that because the context has changed, their environment has changed, the psychological inputs have changed, etc. When you get into like exercise, particularly resistance training, and you start talking about, all right, well, what are meaningful biological changes here? Like where, how much weight should we give to biological causes? I think it's going to be dependent on each different type of injury and each individual. Mainly what you'd want to know is, well, how likely is a biological cause, and what specific biological cause is there? How likely is it to change what I do, to change my management for that individual? So for example, if somebody has knee pain, right, and it's from and they on an MRI or other type of advanced imaging, they have evidence of meniscus, sort of injury, and maybe some edema of a tendon. And so you're like, oh, maybe they have a tendinopathy or whatever. Like, does that actually change what I do? Because in that particular case, probably not, unless one is like very, very severe and it's like indication for some sort of surgical management, right? Which in both of those cases I just mentioned is unlikely. But for instance, if they had like a 70% tear of their quadriceps tendon, well, that might be different, particularly in an athlete who's very competitive, jumps a lot, and needs to get that repaired. So I think it's important to not completely jettison the biological component, but also realize its limitations. If understanding the specific and unique biological cause does not change your management, then it may not be important to focus your time there. And then as a correlate to that, like, we should be careful with what language we use and the narratives we build around the biological cause that we think might be causative here. Or at least that's lending a sort of that might be the smoking gun. Because if we think that somebody, for instance, did suffer an acute herniation during resistance training in their back, I wouldn't want to tell that person like, hey, while you were deadlifting, you happened to herniate 3 discs. Look, we've got this MRI. In fact, when that exact case has happened, and I've counseled an individual, most of the time my reply is this, like, hey, we don't have an MRI from like directly before your deadlift to compare it to the one directly after. So we don't know like when this happened. This might be old. It might be new. It's likely to resolve on its own. But because that particular, like, knowing this quote unquote potential biological contributor doesn't change how I manage their case, I'm not going to spend too much time focusing on it and managing, because it just doesn't change. You have a person with low back pain who has no contraindication to exercise other than symptomatic sort of issues, meaning they have pain with some movements, but that's a more complex experience than just this biological thing. I probably wouldn't take it into consideration compared to if somebody only had a single level herniation or a bulging disc, or, oh, you have a torn annulus fibrosis, like, whatever, ruptured annulus fibrosis. Like, it's not something that's going to change what I do. So I think it's important to not forget about biological causes, particularly in acute trauma, but to maybe not focus on it unless you have the inkling or the suspicion that it's going to change your management. And then when you do, be careful about what words you use, the language you use, and the narratives you build around that. Because ultimately, you could really mess somebody up by giving them kinesiophobia. They could be afraid of the movement that they think caused the thing. You could make them gun shy to ever resistance training again, or engaging in resistance training again. You could make them apprehensive about using exercise to decrease their pain, which we know tends to work pretty well for most different types of pain. And then the final arm of this is that most, like, again, identifiable structural abnormalities that you see on imaging do not reliably correlate to the pain experience, and certainly not with the same magnitude. Meaning that somebody could have, a massive rotator cuff tear or lesion on MRI and not have the pain that somebody else has with just a small nick of their labrum. And so those two cases will be managed differently based on symptoms, their goals, their demographic, an overhead, throwing athlete compared to an 85-year-old woman, for instance. So everything, you have to take it all under consideration. And so when I say that also means you cannot eliminate the biological component either, because that would be problematic.
Right. Quinn, what are your thoughts on this?
Yeah, Quinn's been silent for 30 minutes. I love it. He's a great listener, which makes him even more of a hunk.
Yeah. There's a lot here. That's for sure. A lot of great points that are made. Eric, to your original question, does the pendulum swing the other way too far sometimes, I think is what you were getting at. And yes. I think it can. I don't think Ingalls' intention back in the 70s was for us to trichotomize the biopsychosocial model or dichotomize it into, is this a bio patient or is this a psychosocial patient? Yep. But I think that happens. And you go back to the old statistician George Box, where he says all models are wrong, but some are useful.
Yep.
I think the biopsychosocial model is probably the most useful one we have right now. It doesn't mean that we can't misuse and misinterpret it, though. And there was actually a great paper recently by two authors that were on Barbell Medicine's Rehab podcast. They were on our podcast too. So two great interviews. I listened to your guys' awesome stuff. So Peter Stillwell and Catherine Harmon, check out both of those shows. They just authored it's a proposed extension of the biopsychosocial model. It's called The Inactive Approach to Pain Beyond the Biopsychosocial Model. That is the title. And they propose this 5E model. Now, I'm not going to get into what these 5 E's are. You can read the paper. There's a read-only open access version online. But their point was just that. We tend to still, even though we have this, the biopsychosocial model is meant for us to understand the dynamic interplay between these subsystems and to confirm the fact that we can't just separate out these sides. They interact with each other, but we still do it. It's an acute ankle sprain. This is a bio patient. This is somebody who's had low back pain, non-specific low back pain for 10 years. MRIs are inconclusive, blah, blah, blah. They're a psychosocial patient. We do that. And so I think that we do take these things too far the other way sometimes, that if bio didn't matter, what are we training for? And that's, for me, currently, my interventions, the plans that I write are based on their physical goals, and the pain experience is managed through the process. I don't currently set goals based around the pain experience because it is so chaotic and unpredictable and nonlinear, and I feel like that would set somebody up for failure potentially. So, for example, say we objectify your pain. Currently, your baseline is a 4 out of 10, whatever that means. The worst pain that you've experienced, you've defined as an 8 out of 10, whatever that means. We anchor it. We anchor those scales by saying a 0 is no pain at all. You feel completely normal. Like we shouldn't be having this conversation. A 10 is we're going to the emergency room right now. That tends to be how that scale is anchored. And so based on past experience, I say that the worst pain I experience is an 8, and the best pain that I experience is a 4. So you're always a pain, even right now sitting in front of me. Yep, I'm a 4. Okay. Not going to argue with it. 8 is an 8. 8's your 8. 10's your 10. If you say you're a 10, fine. I'm going to reiterate the point. Like, oh, we're going to the emergency room, right? Yeah. But if I say, okay, our goal is in 3 months, I want to take your baseline from a 4 to a 2. So what does that mean? Is a 2, is that's a clinically meaningful, important difference maybe in literature? Is that meaningful to the patient? What does that mean exactly? And what happens if that patient improves their function? So they are closer to their functional goals, their physical activity goals in 3 months than when they came to see me, but yet their pain is still at a 4. It's not at the 2. They may perceive that as a failed bout of rehab because we framed their goals around the pain experience as opposed to reframing the pain experience as something that maybe we can hopefully manage. Is it possible that your pain goes completely, we're talking chronic cases here a lot of times. Is it possible that it just goes away and you just never experience this particular pain again? Yeah, sure, that's possible. I can't guarantee that. What I can help with is that we can manage that experience and make sure it is manageable for you, and then we can move forward towards your goals. And we can define success in a myriad of ways. We could say your pain experience. I ask them, I say, what would you think about this? Worst case scenario, your pain experience doesn't really change. However, you are better able to do the things that you want to do. They say, well, yeah, that'd be awesome. I'd take that. Say, okay, cool. But you're okay with the pain experience not changing, but it does change though, because they reframe it. They're now okay with being able to manage this as opposed to coming in my door and saying, I want to be pain-free. That goal, when I see that on my intake form, short-term goals, be pain-free. And especially when this is a patient that's been experiencing this pain for years. Be pain-free, 6 weeks, that type of thing. Those narratives are better served to be reframed for the success of our bout of rehab. And if I can frame our interventions around the things that they actually want to do, make their pain experience less scary, more manageable, surprise them a little bit with what they can do when they didn't think that they could do it, I think we're on the right track. Jordan's brought up some great points about structure. And, we get the people that walk in the door with MRI in hand or 3 MRIs in hand, and it's definitely a barrier to entry. But these aren't things that we don't have to overload our education either. We can pick our battles. We can find an entry point. So somebody who is enamored with their MRI about all of the things that are wrong with their back and how they have an 80-year-old back and they're only 30 years old, blah, 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 et cetera, yada, yada. We can acknowledge the fact that they feel that way, that they're obviously scared and worried about these things, but we don't have to have a 2-hour kumbaya conversation in the session either. We can say, okay, I hear you, and those things could be contributing factors to this whole situation. But here's the thing. Even if you didn't have this MRI and you were experiencing these symptoms, here's what the plan would be. Here's what we're going to modify. Here's what we're going to change here. You're going to try this, but maybe we'll tone down that for a while. It doesn't change because you have this MRI showing XYZ. I don't have annular tear templates for you. I don't have
great market
lumbar disc rehab templates for you. Your goal is deadlifting, or your goal is being more physically active for XYZ. I can help you get back to that. I can modify and we can start where you are there, and then we can manage this experience. But these findings don't necessarily change what I do. It's exactly the point that Jordan was making before. So I take a very similar approach in clinic as I do when I'm coaching my competitive lifters who are not injured, or even my field sport athletes that we work with. It's this constraints-led approach, kind of taking some principles from dynamical systems and ecological dynamics. What are the factors, what are the variables that we can manipulate for this person to get them doing something that resembles the thing that they ultimately want to do, and keeping our pulse on their response? So with lifting, it's actually pretty damn easy. We've got external load. We've got volume as maybe defined as tonnage or something like that, just training load in general. We've got range of motion. We've got tempo from full effort, high rate of force, all the way down to isometrics that we can manipulate. We've got range of motion, variation of the task, of the goal task, some type of maybe lateralization or a slight regression, but it's still a relatively challenging variation of the movement. Position within the specific movement. So maybe we do change your stance for the short term. Give your body just a slightly different loading pattern than what you were subjecting to it before, the pattern that seems to be sensitized currently. We change your torso positioning. We give you a different bar that just ultimately changes your body positioning dictated by the task. So that's an emergent property right there. But, as clinicians, we ignore that low-hanging fruit and we go after all the fancy shit that I think Eric alluded to a little bit earlier. But it's like sometimes, how about you just chop off the top end intensity for a bit? Because you're telling me that your anterior knee pain only occurs at 93% of your 1 rep max. Every time you go heavy in the back squat, you experience your issues. Okay, cool. Well, there's 92 other percentage points that we can use to continue your training. It doesn't have to be all or nothing. So for me right now, it's this constraints-based approach, manipulating these training variables as much or as little as we need to keep them training as normally as possible, continue a training effect as well as possible, mitigate deconditioning, because if there's anything that increases risk, it's taking time completely off, as we tend to decondition, jump right back into where we think we should be, and potentially have another setback. And then within that, we are managing their pain experience by just monitoring their response. Okay, you had a flare-up, no big deal. Mother Nature is going to do her thing. It's going to calm down. We'll modify this, and this in the interim, and then kind of work back as we go. But it's not that much different from training. Pain is just more of an abrupt confounder because it's a little scary versus just, this is fatigue that I feel from training. Well, fatigue is normal. I should be tired because I'm an athlete and I'm training hard, but this is a pain experience. It must be completely different. This must abide by different principles, but it doesn't necessarily have to.
Yeah, Quinn, I think you made a great point where about the imaging, where you don't have a template for an annular tear, or you don't have a template for impingement versus non-specific shoulder pain, right? And I think it's if you compare it to something like an infection or like from a blood test, right? So someone is sick, they get, I'm oversimplifying this, of course, but someone's sick, they get a blood test and they find a certain bacteria in it. If they go to 5 different doctors and they get that blood test, they're probably going to get the same result of that test. And then the treatment is probably going to be the same string of antibiotics to treat that certain bacteria. We're just not there yet in what we do. I mean, we don't have these templates. If you go to 5 different physical therapists, there's 8 different offices on the street that I have the office on. If you go to all different therapists, you're going to get different diagnoses, different treatments, different narratives. So we're just not there. And I think that's important to explain to patients. I think it makes it difficult when not everyone is, not all of us are saying that to our patients. I think sometimes practitioners give patients false narratives and they say they have these answers, they have these treatments. If you have this type of low back pain, this is the type of treatment that is going to help it. And it kind of makes us look like we don't know what we're talking about sometimes. And I think it's just that was a great point. How the imaging, it's good, but is it really going to change what we do? Like Jordan said before too, I think imaging is good for ruling out red flags, but it's not really going to impact what we do here. It may even hurt it, right? It may even put these things in the patient's minds, like their discs are going to explode out of their backs, or they have bone-on-bone arthritis, or they have a meniscus tear, or they have a different arthritic changes in their joints, and I think sometimes too much information that isn't going to have an impact on what we do is a bad thing.
It's interesting. I think what I'm hearing, and I'd be curious to see if I'm hearing it correctly, is that, like you said, Quinn, the constraints-led approach is basically very much like, well, what are we going to do? And what can we know? Which in the end is exactly the only thing you can rely on. And Nick, what you're saying, kind of comparing some of the more well-established, clear-cut black and white medicine that has, a very grounded biological outcome, and it may differ on recovery times, but if you've got a bacterial infection, antibiotics are probably the answer, like you were saying.
Or CBD oil.
Correct. Yeah. Well, one of the two big options.
What's your discount code?
Yeah,
exactly.
Douchebag 10. Click the link in bio.
Is that the number 10 or the letters 10?
We'll put it in the show notes. Don't worry.
Yeah, show notes, yeah.
You need to make your affiliate commission. You think Barbell Medicine pays for itself? Come on now.
Yeah. This is a business, man. Come on. So, if we had not only complete but perfect and relevant information, like some type of super scanner that could tell you, is there tissue damage? And not only that, but is it adaptive or not? And also, does it matter just now? Or, okay, it's fine now, but 30 years from now, you might need a hip replacement if you don't deal with this. Like the level of information we can have is limited. So function does seem to be the pathway to go. But I think what I'm getting is it's super context dependent. Like, just to disclose a little bit about myself, I just did a strongman comp. And I knew, and here's an interesting finding, was that I could tell my pain was not reliable during the comp because but I knew that, and that helped. Because my adrenaline was going so much. So I did a 125 kg Atlas stone. And what you do with stones is you jam your fingers underneath the stone, and it should be literally sitting on your fingers. And in training, every time I did that, even with a 70 kilo stone, it hurt like a bitch. It felt like, a 70 kilo stone sitting on my fingers, right? Unsurprisingly. But in competition, nearly twice that weight sitting on my fingers, I felt nothing. Like, it was just... There was pressure on my fingers, and I was like, okay, so pain's not really doing its thing right now. I'm hyped up, I'm competing, I'm excited, I'm motivated. There's a lot of things I'm focusing on. That's not in my brain. So when I felt that I had what felt like but didn't have pain, the movement of a bicep tear on one of my warm-ups on stones, I couldn't tell whether that was serious or not. While in training, I think it actually would have hurt a great deal. So I needed imaging to find out whether or not I had a partial or grade 1 or full freaking long head biceps tear. And that was useful, but that might not be useful in many other contexts. And knowing the limitations of the biopsychosocial model of pain and paying attention helped me get a better idea of where I was at in the moment to use my pain as a useful signal, which is my personal experience. So I guess, I don't know that I made a really solid point there.
Well, I think we should bring up for everyone out there, Jordan, Quinn, Nick, you guys are talking about pain management, reducing pain, but we need to be inclusive here. What about people that want to actually increase pain, the masochists out there? We've been talking this whole time, let's reduce pain. What if I want more pain? Okay, like several years ago, I was doing a low bar squat. I was doing my 5x5s. I went for 505. I found out I was squatting, missed it, cool, whatever. I felt something explode on my hip. I'm like, that's just pain leaving the body, baby. And then years later, I end up squatting 495. So it's pain leaving the body. But if I want more of that feeling inside, how do I experience the pain if I've just grown numb to everything? Now I'm aware of the biopsychosocial model. I can't inflict that same self-harm. And if you're worth your weight as a powerlifter, hurting yourself is probably, like, PRs are here, self-inflicted harm's probably right here. So I don't know if I agree with everything that everyone's saying, quite frankly.
I actually wrote an article last month for our research review called "The Fourth Powerlift Injury," and it covers some things that you could do to actually increase your pain if you wanted to. So thing number one, if you have perfectionistic tendencies, if you're very, very cerebral about all of the things that you're doing and everything has to be perfect. If it's not just perfect, you're frustrated and mad and then you can increase injury risk. Additionally, if you are hypervigilant to a particular cue or set of cues or overall sort of insult to the body, meaning like, oh, my knees caved in at the bottom of the squat. Oh God, somebody told me that's, boom, meniscus exploded upon knee valgus. You can have more pain if you are hypervigilant. And that's something we actually see in sensitized individuals. For example, they won't go in a full range of motion squat because their back hurts, right? Because they're sensitized to that, and they're guarding against going through that full range of motion, mainly because they're hyper vigilant. And so, and then with that in mind, you could also just build a bunch of terrible narratives around movement, and really get somebody freaked out about, like if you ever let your knees slide forward in the bottom of the squat, if you let your back round in a deadlift, or if you let your shoulders protract off the bench in a bench press, you're flirting with disaster. You're gonna hurt yourself. And all of these things, you can get somebody to effectively, they would have had a neutral sort of stimulus. And then now through their new lens that's been socially cultured, they've been conditioned in a way to they might actually have more pain than they otherwise would. So if you really want to take it up, the other thing you could do is layer in a bunch of environmental stress and fatigue on somebody. So for instance, you could like re-enroll in college and then just do finals every week if you wanted, just like finals week over and over and over again, and keep your training the same and not auto-regulate it. That'd be a good way to increase your incidence of injury. You could go through like a nasty breakup on a regular basis. You could have socioeconomic instability, and again, really try to ramp up the training stress. And then finally, what you could do is if you were coming off a program that was pretty low in volume, and only of moderate intensity, and you did something like Smolov or something like that, you could really find a way to mess yourself up by just rapidly increasing the training stress that you're applying to somebody. And again, while being a perfectionist, being hypervigilant, and all of those things would tend to predict or at least increase risk of injury.
I was joking, Jordan. I was going to say, how do you, as individual? But it's leading to something that it's leading to something that you brought up that I wanted to follow, and that was going to essentially be the question: is as practitioners, the variability of the individual, where you have, Jordan, on one hand, let's say someone with a perfectionist attitude, or those leaning towards being hyper cautious, super aware, and that's why I joked because powerlifting's near and dear to my heart. But I was at Pasta Bosses too. I've seen, let's say, tested, untested, lifters, their mindset, how they approach training. And I think it depends upon the group that you're teaching or the audience that you're speaking to, where for the average person, let's say, it's like, you're being way too cautious here. You're using this as a wrong signal for what's going on. But then on the other hand, I wanted to ask you and everyone else here, how do you deal with that individual variability where there are some of those shut up and lifters where nothing registers with them, but they always have maybe these reoccurring problems that they're consistently ignoring. In other words, they're almost closed off to even the idea that they should limit, change any parameters, any variables, and they're, I don't want to say quite on the opposite end of the spectrum, but rather than be cautious, like, hell yeah, man, let's go all the way in here. Oh, I got to tear like there's actually an anecdote. And I don't think they'd be interested in any injury prevention or getting back to it, but it was Dave Tate training with someone, and the individual, and this is what I heard in a podcast, the individual snapped their pec, I think it was, doing 315, and they laughed at him, and they told him to rack the weight on it on his own, and so we talk about power.
Too late.
Yeah, he's now dead.
Yeah.
That injury doesn't count.
And so to say, this evidence-based community, I'd say, is a little bit more self-aware. They think about these things. Maybe they think too fucking much. But when we talk about powerlifting as a whole or individuals that lift, there is that contingent of people that kind of just keep lifting. So in your experience, the three of you handling a wide variety of people, is it a one-size-fits-all approach, or have you encountered, for instance, Jordan, someone was like, oh, maybe, these variables, like some of these things where you spoke about technique, is like, I don't know, like your shit just looks whack. Like it looks really whack here. Have you ever filmed yourself lifting? We need to dial this stuff back.
Yeah, I actually talked to Omar about this. Like I think there's a big difference between talking about people with fibromyalgia who has something like if I recall correctly, 9 out of 10 of them have had some history of emotional trauma, which it probably is some underlying factor which is keeping their car alarm on a lot, versus the lifting community where, man, if anything, they're more likely to want pain not to matter. And they're like, oh yeah, great, you're telling me what I want to hear already. Like, awesome. Yeah. So I'm curious to hear you guys' thoughts on that.
And I think most of the time, particularly when you're dealing with competitive athletes across all sports, one thing that we have to keep in mind is that athletes will tend to underreport injury or signs of injury because they think it's going to limit their play, which it often does, particularly in organized sports where there's either an academic institution like college sports or high school sports that's kind of overseeing this, or a professional community that basically has stringent guidelines for like, oh, you can't return to play after this particular injury until this much time, or a doctor clears you or whatever. So people will tend to underreport. But with respect to just lifting in particular, most lifters, particularly competitive lifters, tend to be outcome focused, goal directed, meaning that above anything else, they want their total to go up, lifts to go up, their performance to improve. And so I think, like Quinn mentioned so elegantly, my friend, you got to find a place to get in, right? Like an access point. And so for, I think, the lifter who maybe would eschew all of the stuff that we've been talking about so far, one way that you could get some leverage would be to go in and say, well, don't you want your total to go up? Mm. And don't you think that if you could train more consistently, more productively for a longer period of time, sans injury, like that might occur. And so within that, you're trying to work with them. So for instance, I'm thinking of less than a handful of clients right now who I might write on the program like, hey, I want you to work up to a set of 4 at RP 8 or 2 reps in reserve. Here's a ballpark percentage point that you should probably get towards. But no matter what I write, it doesn't matter. They're going to take it to 10, maybe 11. It just, and so after beating my head against the wall for a long enough time, one thing that I do is I'll actually program them to go to 10. Like, hey, go up there. But then the back off work is actually going to be significantly lighter in an effort to try to modulate the total stress, right? To kind of bring it down to a point that I think that we can actually build work capacity, get some useful training volume in, and then ultimately kind of extend the length that they're able to train productively. So that's one strategy that I use. And I gain access to this from this goal-directed sort of standpoint. The other thing that I try to, with respect to technique in particular, because I would identify as a technique nihilist overall, as it pertains to injury risk reduction. We're talking about strictly exercise technique. But with respect to performance, I'm more discerning, and I think there's a bigger role to play for exercise technique on actual outcomes, meaning that finding the efficient way to move the barbell in a artificially constrained and defined range of motion that is powerlifting or Olympic weightlifting, you could actually make a case for more sort of technique management to improve performance. And again, I think if these people are mostly goal directed, you can kind of that's the way you can access them or speak to them and something that's actually meaningful. Because if I just say, hey, yeah, if you keep doing it this way, I think you're going to have problems. They're like, well, what kind of problems? And then being a scientist, I'm like, well, I mean, I don't really know, the injury rate and resistance training and competitive powerlifting is this. So, maybe not that much or maybe a lot. I don't know. And they're like, sounds like you're waffling, doc. Like, give me something to sink my teeth into. I say, yeah, but I think you might be able to add some to your squat if you change your technique up. Just do these few things. And they go, ooh, well, now you're speaking. Now you're speaking my language, because Boss of Bosses 8's just a year away. And so I got to do this. One thing I also just wanted, this is unrelated. Well, it's not unrelated, but it's interesting and provocative, which is, that's my middle name. That's like a hyphen. It's Jordan, interesting, hyphen, provocative, Feigenbaum. Yeah, it gets me. So the notion like anabolic steroid use actually increases injury is so super fascinating to me, mainly because in almost every discussion of resistance training induced injuries, it comes up. It's just in there. Like, you could download the article and then you just Control F, find anabolic steroids. There's like just a mention of it. But there's actually only 2 case reports that have been published on this. Like, what is there an increased risk of injury with anabolic steroid use? And both of them have to do with upper body exercise, specifically a biceps tendon rupture or any sort of injury that occurs from the bench press. And there does seem to be a higher, incidence of injury in those who self-reported using anabolic steroids while they were actually training. But we don't have good, robust data suggesting this. But this leads me
Are
to think
you
about
saying that because I have a bicep strain that I'm actually a fake natty? I am so offended.
I'm about to take off my shirt and defend my coach. You better.
natty or not. Well, the interesting thing is thinking about this is trying to think about mechanistically, like, why would this be? Right. So you have somebody who's motivated enough to use anabolic steroids to increase their performance, likely, or their social currency if they're, an Instagram lifter or whatever. And so you think about, like, well, how would that actually maybe result in an increased injury incidence? So you kind of go through this. You're like, all right, well, they can handle more weight. So you could increase the acute workload. And they may not have previously been trained up to that point. They're just able to acutely increase their workload compared to what they previously trained with. And so maybe this acute on chronic workload mismatch could be problematic. That's one thing. The next sort of thing is more just strictly biological, right? If you went down this pathway, you're like, well, maybe the steroids the anabolic steroids themselves are better at increasing muscle cross-sectional area than actually increasing, tendon or ligament sort of thickness, resilience, stiffness, other properties, structural properties. And there's some evidence for that as well. And then the third part is this sort of psychological approach. Mm-hmm. So effectively, when there's placebo studies on steroids that are like, yeah, if you think you're taking steroids, you'll lift heavier, right, and able to perform better than if you, even if you are taking anabolic agents, but you don't think that you're taking them. So it's super fascinating that there's multiple ways where this could happen.
My guess would just be that people that take anabolic steroids are generally less or more willing to take risks.
Yeah.
Yeah, sure. Engaged in risky behaviors. Sure. Yeah. You walk out 300 kilos and you're like, I don't know, man. Let's take it for a ride.
See what happens.
Yeah. Meanwhile, I have a very it's actually just two different versions of Austin on my shoulder. Like, it's the good Austin on one shoulder, and he's like, yeah, man, you should go for it. You've got this. And the other one is like, you might not have this, but you should do it anyway. It's like it's a good Austin, the bad Austin. So I just think it's an interesting question to me, although I don't think we have an answer. Yeah. Again, just to recapitulate, I think Quinn really gave us a little pearl there. Is find an access point where you get some leverage and start working with an individual based on their terms, meet them where they're at, and then you can kind of grow from there.
Mm. Yeah, Omar, I think to your question, I think the phrase "it depends" always seems like it's a cop-out, right? Like, it depends. But this is the stuff that we're talking about when we say it depends, because each patient or client is so different. So you have to change your approach, what you're educating about, depending on the person. So if the person is hyper aware of their pain and they're fearful of movement, you don't want to, like Quinn was saying before, you don't want to ask them, rate your pain. Is your pain better, worse, or the same? Okay, squat again. Is your pain better, worse, or the same? That's almost like breaking up with a girlfriend and someone you spend 2 weeks eating ice cream on the couch, and then you finally get out with your friends, and the first thing everyone says to you is, so how are you doing? How you doing? I saw her on social media. How are you doing with the breakup? And sometimes for that type of person, you don't want to, you don't want to have them focus on pain. You don't want to ask them about their pain. But then the other person, like you're saying, who just kind of plows through the pain, that person, you may want to say, look, man, like, if you keep flaring this thing up, it's not going to calm down. So I think it comes down to listening, just listening to the patient, listening to them talk about their injury, talk about their life, talk about their goals. And I think we can find most of our answers and get the right approach just by listening, rather than having like this army of education that we're ready to like throw on them. I think if we just listen with the intent to understand first, then I think that it will guide us to kind of the right approach and which tactics to kind of use to best treat that patient.
Quinn, anything?
What was the original question?
It was
Omar. What did you even ask?
Something about steroids.
What's the meaning of life? Yeah, is RP12 is how do you deal with the individual variability of a patient when it comes to, on one hand, let's say Jordan was describing the highly cautious perfectionist individual that's more prone to believing, oh, I'm gonna get injured, and that's why I wasn't quite alluding to someone that is enhanced, but someone, let's say, that is more of a risk taker, that prefers to ignore some of these warnings and really just wants to get out there, smash some PRs, pain is weakness, leaving the body. We call them, jokingly, I refer, shut up and lifters.
Yeah, the person you'd have to tell not to train the day after FAI surgery, you know?
Yeah. That's right. I remember. Who's that guy?
I've seen a few.
Jordan brought up a good point about changing the way that you program to accommodate those lifters that you know are just going to kind of go over the edge, regardless of what you say. I like the idea of prescribing higher intensities so that back down is just naturally lighter. It kind of self-organizes that way, right? So that their working sets take enough out of them where they can't just crush themselves on volume. And I've taken a similar approach, knowing that I can keep beating my head against the wall, telling this person things, or I can just program a little differently to accommodate the type of person that they are. So maybe it's lower volume. We still got to lift heavy. That's the nature of the sport, but perhaps it's just not as much work, or perhaps we have a conversation about frequency. Take out a day. If each training day is that much more intense than it needs to be, but that's just consistently happening over and over and over, we can modify overall workload that way. The other piece of this is just being straight up with these people. I don't, I have no problem repeating myself over and over again until somebody gets it. Some people just aren't quite ready to listen. And if they keep going above and beyond the program, and then they come to me complaining about some certain things that perhaps continuously overreaching during these training sessions is accumulating some type of thing, might be a contributing factor to this issue, I'll just calmly reiterate the fact that I hear you, man. We'll keep managing this thing. But if you look on this day, and this day, you went a little bit more intensely than prescribed, or you did a little bit more work than was prescribed, and you did this. So if the lifter wants, it's not ultimately my job to change them as a human, to make them a better listener, or to calm down that inner rage that they have. That's just who they are. And if they're not willing to listen to me and they keep running into problems that I think could be helped by listening to me, then so be it. I again, like I said, I've got no problem just repeating myself until it kind of clicks with them. And I find that these type of people eventually will listen. If you just keep saying the same thing, hey man, again, XYZ, again, we could try this. So if you're coming to me with the same problem, obviously the way that things are going right now is not working. So I'll say it again, XYZ. It tends to be effective. It's just, that's kind of a painful process. It's painful for me too, because it's frustrating, especially with my in-person lifters, where I'm saying this for the 500th time as if I'm saying it for the first time. And that's always what I try to instill is say it like it's the first time you said it. But it can be tough. But I think just constant reiteration, and eventually perhaps modifying the program to accommodate. But it helps when your goals are performance-based as well, because at least those people are going towards that piece of things, and they're not so enamored with the pain process that I have to have that conversation, because sometimes that conversation can be a little bit more problematic in terms of reframing and trying to nudge the needle a little bit towards our goal. So it's kind of like pick your poison. I think I'd maybe rather have the hard charger in a lot of different instances. But
yep,
one thing I wanted, before I forget, because as Nick and Jordan have been talking, I've been thinking about this notion of graded exposure, which Nick brought up, and then the idea of this concept of how pain can kind of create some fear avoidance and these types of negative beliefs in regards to moving. So it was, Jordan brought the example of perhaps it's low back pain and I don't want to pick up that bar from the floor because I think it's going to hurt. Or you become, in the cases of chronic pain experience, you become the guy with the bad back. I'm just the guy with the bad knees. You have your program comes up this week and coaches, it's a new block, squat frequency is increased. You're like, oh shit, my knees are going to be killing me during this block. And it's like this this foregone conclusion. And within this, we get into how do the things that we do in the clinic, how do they actually matter? If we know that long-term adaptation doesn't happen in an hour's time, what is the thing that's happening when somebody walks out in a better spot, either mentally even or physically? They feel better walking out of the clinic than they do walking in. That phenomenon. And I think that's where we get caught up in some of, I call it the Mount Rushmore of PT exercises. It's like the sideline clamshell, the glute bridge, the front plank, and whatever else you want to throw in there. These low level, low load exercises. That novelty is powerful. So if your back is a little achy or you have a little pinching in your hip when you squat, many more kilos than a glute bridge is going to afford as far as load on the tissues, but yet you haven't done a glute bridge since you were like 12, and then you just go ham on glute bridges in the clinic and you burn the hell out of your hip and you all of this novel input, and you get up and you kind of move your hip around like, oh, that kind of feels better. The problem with that then is that you think it was the glute bridge that was missing this entire time.
Post hoc ergo propter,
yeah. When it's really just this novel thing, and it's the belief of the clinician. And what if the clinician loves glute bridges? It's probably going to work that much more because they're going to be like, yeah, this is the exercise, right? But that novelty is going to wear off. The glute bridge will no longer, at some point, most likely no longer afford you that kind of novel stimulus for that change in perception. And then you'll be looking for the next quick thing, this quick fix. It wasn't the glute bridge, duh. It was the Copenhagen adduction lift. It was my adductor that needs to be facilitated, not my glute. God damn it! Because when I did the adductor exercise, I got the same response, and so it's this vicious cycle. Now, what's happening? This novel stimulus. But if we take a top-down approach, not that those things can't be layered in, and of course, if we're talking post-op and they have a very low barrier to entry in regards to load, sometimes that is the training until we reach a certain point. But we're taking this top-down approach to training modification, where we try to make the intervention still creating some type of response. We get into this graded exposure principle, which comes out of psychology. And this concept of predictive processing, where somebody who's experiencing pain may predict that they will be in pain if they try X, Y, Z. They know their triggers. They know how they got hurt in the first place. We tend to then equate that with threat and danger. So we're going to be a little bit more cautious and maybe a little bit hypervigilant, as Jordan was saying, or perseverate on that thing. So you go in with back pain, you hurt yourself with a deadlift, and you have back pain now, and it was 2-3 months ago, whatever. And you come in and say, all right, well, I want to grade your exposure back to your trigger movement, and I want to assess your load tolerance. So go over there, and we're going to work up to a max effort deadlift today. And they say, whoa, okay, so we're not grading the exposure, we're just crushing them. So these negative predictions come back to the forefront. They predict that they're going to be in pain. They go to pull a heavy deadlift, they are in pain. It more deeply roots that negative prediction. So it's even stronger for the next time. This is when you get into that vicious cycle of I'm just the guy with the bad back. What I think where some of the magic happens in clinic, where we have a short time period with people, there's no way that any long-term adaptation is occurring in that short time period, but yet we can still make progress, is this concept of altering these predictions, going from negative predictions to being coach clinician, learning how to course correct just enough to provide them with that entry point to loading that they didn't think they had before. And now we start to perturb those negative predictions a little bit. Perhaps if we go from blocks, you hurt yourself going off the floor at X amount of weight. What if we go from blocks at X amount of weight, or even 75% of the weight that you got hurt, but from blocks? Oh, I don't know. It's probably still going to hurt. If it doesn't, that's now an entry point to load, grading the exposure to the trigger movement, ultimately the goal activity, potentially changing some of that predictive processing mechanism, changing those priors, so to speak, update your priors, bro, to something a little bit more conducive to actually moving forward with our goal. So I think potentially that's where some of the magic is happening in the clinic. and that's where that graded exposure effect can have some power. It is reshaping their beliefs. And I think that's powerful. And I think that is the misconception with some of these exercises that have that immediate effect, that novel exercise-induced analgesia, like that's somehow, like with tendinopathy literature, these isometric leg extensions, holding them, making your quad burn, sending a strong sensory input to the area that you haven't had in the past, and then you kind of walk around, do a single leg squat, and you're like, oh, my knee feels a little bit better. Holy shit, isometrics for tendon pain. That's the secret. That's the prescription. No, exercise analgesia is a phenomenon that happens all the time. I mean, hell, it's called a warm-up. I go into the gym feeling like shit all the time, and then I squat a little bit, I move around, and I get warm, and I feel better. And there's no magic to that necessarily. So there's the other narrative of, well, you're in pain or you're experiencing pain because X, Y, and Z is weak. The problem there is, or it just gets stronger. Strength training is your ticket. You need to be stronger. Well, where's the cutoff there? I have people lying on my treatment table who squat 900 pounds, and they are telling me that they experience pain. How strong is
Quinn,
it's not 1,000.
Yeah,
that's
so
probably
four digits is the cutoff. Yeah.
That's probably the inflection point.
But I've heard Ray Williams has no pain, so that's the.
He's got his wearing a bracelet, bro.
I believe that. And so it goes back to this. Okay, it's not being a certain level of strong, but it's something's happening during the process of strength training that is altering this chain of events or this perception action coupling. And I think maybe that's where the magic is happening. It's just so hard to quantify that and to explain that in terms of other than, well, this thing over here is giving you problems. Let's try this thing and see if that helps, and this thing will calm down, and then we'll work you back over there. Mm-hmm. Which, if we simplify it all the way down, is pretty much what we do.
I mean, there is so much to unpack here. I honestly think there could be a whole other episode. I do want to, Coach, if it's okay, go off on a small tangent here to something that Jordan said. Tangent away. There's so many things. But when you brought up one of my favorite topics, Jordan, you said nihilism. I love Dostoevsky, Turgenev. I'm reading Fathers and Sons, the 1860s Russian radical movement, all about it. But more specifically, technique nihilism, which I find interesting. I think in the denial of any importance of technique when it comes to preventing injuries, you made the point, efficiency of movement when it comes to maximizing the lift. Technique might come into play, but when it comes to preventing injury, technique is inconsequential. I'm not trying to put words in your mouth, but can you just define what you said first before I ask the follow-up?
Sure, yeah. So I think for injury risk reduction, because we can't really prevent injuries, we can reduce the risk. For the general strength training population, that technique is of little to no consequence. Meaning, and just very specifically, meaning that if your knees cave in at the bottom of a squat, if your back rounds in a deadlift, if your shoulders protract off a bench press or similar error, then I don't think you have an increased risk of injury. Your trainability of the lift may decrease because your efficiency is down, your technique's all over the place, and that might impact your ability to build work capacity in a particular movement. However, I think that most people's technique tends to self-resolve over time. They just figure out how to organize themselves, even if they don't have a coach. And so that tends to go away. But people who are hypervigilant towards technique actually think of an increased injury risk compared to those who are more flexible. So we'll call it technique flexible. How about that?
Yeah, and that's what. Oh, go on.
I'm going to go ahead and I'll actually, being the non-expert on the panel, but still challenge you on this, because I think the first sentence you said there is not the same as all the sentences that followed it. I totally agree that technique does resolve itself over time, and sometimes, and that hypervigilance will negatively impact one's likelihood of injury or their perception of pain, and that I'd also say that we can't, just by nature of the way the scientific studies are conducted and what we can prospectively know and retrospectively know, reliably tease out how technique results in injuries. But that's not the same as saying that we are confident in knowing that technique has no impact on injury.
Sure. Yeah, I guess from a scientific standpoint, I
Like absence of evidence is not evidence of absence.
Sure.
Right?
I'm unable to define what good technique even is, to define that. And I'm unable to confidently say that technique has a meaningful impact on injury risk reduction. That being said, given what I do know about factors that do reduce injury risk, I am fairly confident at this point, given the existing data, that deviations in exercise technique are not a large factor for injury risk in resistance training. And that stems from just a low overall incidence of injury or injury rate in resistance training compared to other non-contact sports, the nature of injury occurrence in resistance training, and then again the actual risk factors that do contribute to injury risk development in resistance training. So none of those things are related to technique, even from a plausibility sort of standpoint. So I'm kind of like, so for instance, acute on chronic workload, big injury risk potential there, and then in addition to just being untrained, big injury risk factor there. In addition to sort of the psychosocial stuff that we've already discussed with respect to hypervigilance, perfectionism, things of that nature. So if there was something that was like, the theoretical counter argument is like, yeah, sure. Well, during soccer or during running exercise, running sports that involve running, we know that if you cut and plant and twist and stuff like this, then you have a higher injury risk when it comes to like ACL ruptures or knee injuries, however, depending on how you define injuries. That's true. That's true. Although the kind of that doesn't necessarily translate to resistance training, thing one, and then thing two, we think that's actually more secondary to a decrease in strength, and then also an anthropometric sort of an anthropometric like
predisposition,
issue.
like women who have greater Q angle. Sure. Yeah.
Just shorter individuals in general, for example, but being weaker, anthropometric predisposition. But we don't necessarily think like you could like coach somebody to use a different technique anyway. This is just a strategy they're going to use. So the final part of this is let's say that technique was had some mild predictive value or small predictive value or even moderate predictive value for injury risk. Can you affect this prospectively, meaning that can you take a new lifter and change their technique? My argument to that is not really. You can give them cues, you can limit the maybe exercises that they're exposed to or whatever, but you're really unable to change a lot of their movement patterns until they've actually had more experience under the bar. But the confounding variable there is that they've actually built work capacity. They've built some acute, training load that they now are able to tolerate more and more training.
Sure.
So one thing that we see that tends to be very useful in untrained, previously sedentary populations is limiting their total workload. And so effectively, you don't let somebody go up to like a 1RM on their first session, or you don't let somebody max out, early on in their resistance training career because they don't have that sort of history, that base of training. And so to the degree that any sort of technique error could maybe even potentially hurt them, you're minimizing that, even though, again, I think the way I view it right now is that it's probably not a big factor, and becomes less of a factor also, I would say, as people become more and more trained. The classic example is the person who rounds their back during their every deadlift on a platform, because it shortens the moment arm between the hips and the bar. That's how they prefer to perform the movement. Whatever, they've trained it for years and years and years. I'm cool with it.
Sure, and I think it's important to look at this and what level of granularity can we know about it.
Sure.
Like for example, if we compare the injury rates in CrossFit, bodybuilding, strongman, powerlifting, and weightlifting. So this is observational, and we just know rates. They're all lifting, quote unquote. And they're different rates. So bodybuilding typically has about 1/3 on average the rate of injury, using the same injury definition, just to kind of be on the same page, even if we don't agree that's an injury. It has about 1/3 the rate of CrossFit, weightlifting, and powerlifting, which when you kind of collect all the studies and put them together are roughly the same. CrossFit and strongman are probably share the most similarities biomechanically, I would argue, but the difference is load. So maybe now load plus fatigue might result in a higher injury rate in strongman, because you're doing things to fatigue that are heavily loaded. And strongman's way higher injury rates than the rest. And bodybuilding is the lowest. It has the fatigue, but not the load, and typically not any extreme end ranges of motion.
Yeah.
So to me, here's another one. I have a brief question for you, Quinn. How often in weightlifters do you see bicep tears?
Rarely.
Right. They do way more deadlifts than powerlifters. And every time I see a powerlifter with a bicep tear, it's almost always on their underhand grip side of their mixed grip. So I think if we go to the extremes, like I've never personally seen or heard of someone tearing their bicep doing a deadlift with a hook grip or a double overhand grip, but it happens quite commonly observationally in the underhand grip. So that I could give an example where it would be a difficult position to say technique doesn't matter at all. If you were to say, bicep tears tend to occur with a little more when you're, supinated and have a little more elbow flexion.
Sure. If you have a very, very low incidence of injury overall, it's very difficult to tease out the causative nature because you just don't have enough data points. And so you basically, it's just harder to say. But you're right. I mean, when you look at the data on comparing bodybuilding, powerlifting, weightlifting to stuff like strongman and Highland Games, which are the two highest injuries for barbell sports. Strongman is 4.5 to 6 injuries per 1,000 participation hours. Highland Games 7.5 injuries per 1,000 participation hours. Bodybuilding is 0.25 to 1 injury per 1,000 participation hours. So you're like, what are the differences here? And so bodybuilding, sure, lower load, but you also have a pretty high workload just given all the volume and all the sets that they take to near failure, and substantial amounts of fatigue are incurred. One thing that's interesting to think about, though, is the relative familiarity and then also controllable elements of the actual lifts. So, for instance, bodybuilding, a substantial portion of them are going to be either barbell or machine based, and most bodybuilding exercises you could do in any gym anywhere in the world. I mean, just if you're broad strokes.
So are you saying that it keeps your technique in a more single?
No. So what I'm getting at is
the devil's advocate there.
Yeah, sure. No, what I'm getting at is that the strongman, you might not be able to practice the events that you actually see in competition. So for instance, and the relative novelty of the exercises. So for instance, each strongman competition is going to have different events, whether powerlifting is all the same events, and bodybuilding, again, you have more exposure to similar things over and over and over again. Highland Games, way huge variety of different events, and then also just the relative inability to train them. You're like, okay, I don't have access to any of these things, but I'm going to show up, don my kilt, and then go compete. So,
I made that CrossFit comparison.
Yeah, exactly. Yeah. So, what's interesting is you would expect CrossFit to have a substantially higher injury rate than something like powerlifting, but you don't. And the reason why you might expect that is you're like, okay, dynamic movements, wide variety of movements compared to powerlifting or whatever, and then also at near or even maximal loads, you would expect it to be higher, but you just don't. I think what you see is the inflection point between the ability to kind of build up a significant amount of training history, like where you see a bunch of the movements and the exposures that are similar to what you're likely to face in a contest or in your training. And you see that disparity as it plays out between what I like to do is group bodybuilding, powerlifting, and weightlifting together, and then strongman and Highland Games in another group, and then which way does CrossFit sort of trend towards? And it's towards the bodybuilding, powerlifting, and weightlifting. It's just a little bit, I guess people are more familiar, have that sort of training history. And if you've seen the bloopers, CrossFit technique is, you could have a field day with some of that. I mean, it's the same way you could do with powerlifting and weightlifting, although less with weightlifting. Because again, Quinn, you guys wear polos, you guys are quiet during the lifts. It's it's much more refined. But
we bow after a snatch.
Yeah, right. There's actually, it's like golf, really. It's like somebody sitting with a quiet sign, and then afterwards just But powerlifting, you see all sorts of a wide variety of different techniques that occur, and there's not a lot of injuries that occur at the meets either compared to injuries in training, given the same amount of competitive or training hours. So Yeah, I don't know. I think you're exactly right, though, Eric. It's hard to say. There's no, to confidently say there's no link between technique and injury. That'd be a hard position to hold and be a scientist at the same time. But I think my current position is that I don't think that it matters that much based on existing evidence. And I think if new evidence emerges to change my position, I will readily. Yeah,
because techniques is schema, right? When we see technique, we think of someone making a YouTube comment, but really what we're saying is biomechanics.
Sure,
and
yeah.
I can't really see a way that biomechanics can't matter. Like we know that if you are at the end range of motion and maximally loading a lift near the tissue's capacity, there's probably going to be a problem, right? It's obviously an argument of going to the absurd to prove the point, but I think I only do that because I felt the statement that technique doesn't matter is probably not nuanced enough.
Right, sure.
Yeah,
It's a good soundbite, though.
And because that's already what some of the shut up and lifters want to believe.
Yeah, it depends on what camp you're in, which is why I brought that up. I love watching the big boys lift, which is why I kind of hear a lot of that side. And the realm that most people hear, the quote-unquote evidence-based crew, they might not be hearing those sides.
Exactly. Sure. So my clients I've had clients who I've literally told them, you're not allowed to send me a technique video for 3 weeks. Like, I do not, if you show me another squat with a little bit of knee valgus and you ask me if that's okay, or what should I change, or how is that, I'm going to throw away my phone and just go live in the woods. And you'll never have a coach, and no one will have a coach, so stop it. But then you've got the guys who are the opposite end of the spectrum, and they're just like, just lift the weights and nothing matters except the weight on the bar. And I think they will have a lot of confirmation bias, and they hear technique doesn't matter. Like, yep, all those YouTube assholes, I knew it, So
they don't even squat 4 plates.
Yeah. So I don't know, Jordan. I'd love to hear your thoughts on that, and also Nick and Quinn.
Yeah, I think Omar kind of, summed it up nicely when he was talking about nihilism. And my view isn't that there's absolutely no kind of relevance to technique and injury risk reduction, but rather I don't think that it matters that much. I don't get that excited about it. I do think that the more you trend towards a movement being very uncontrolled at high velocities, at near maximal or super maximal loads, then the argument changes. But for most of the cases that we see, and the resistance training population at large, I think that it's a TWUD. It's a time wasted on useless detail. And again, because most of the population that we see tend to have been lifting for some period of time and have what I would just deem acceptable technique. And I can't define that. Like, what does that even mean outside of it being trainable? And that I can define as something that's repeatable, that they're able to mimic the similar movement patterns over and over again, so that you feel comfortable, hey, yeah, go do a couple sets of 5, because that's the magic number. And each rep is going to look somewhat similar to the last rep, rather than it's okay, the first one they dive bomb, they touch their ass to their ankles. The second one was 7 inches above parallel. The third one, they did an actual good morning, but not a squat at all. The fourth one, they dumped the bar off their back, did a RDL, called that a squat. And then the fourth one was a power clean that they did from the rack. It's just.
You saw me train yesterday.
Well, right. Yeah, I know that you're in the CrossFit. So, just less important.
I think that's a really good point, and I think technique is a great tool to measure progress. So I've shot archery my whole life since I was 3 years old, and the thing with archery is that your form is the foundation of everything, right? So if you're trying to adjust your sight to hit the target, your form, you have to be a machine. Every time you pull that string back, it has to be the same exact thing. Like a gun has a mechanism that does the same thing every time. But when you shoot a bow and arrow, you have to be that mechanism, right? So you can't accurately adjust your sight if you're not being consistent with your form, because you don't know if the arrow went a certain way because you moved your arm a different way, right? So same thing with technique. If like Jordan, like you were saying, if all the reps look different, it's hard to measure, did I get that extra rep because I got stronger, or did I just cheat the weight up, right? So I think there's something to being at least consistent with whatever technique you do choose in order to measure progress, at least.
Quinn, you do the most refined style of lifting, and it's something that honestly terrifies me, weightlifting, which is why I wanted to bring the question to you, just because my technique is absolutely trash. It's the more elegant, dynamic, and let's face it, powerful of the disciplines.
Don't worry, technique doesn't matter. You're the best Olympic weightlifter.
Well, that's what I already tell myself, but everyone else says stop doing this. It literally, the bar is falling on your neck, and I said, you don't get it.
You're an embarrassment to the sport. Please stop. Yeah.
But they're just haters, as we know.
So the conversation is going a few different directions because it is difficult to talk about technique and injury when neither thing is defined very well. So to discuss the nuance and to discuss the when it depends, or technique probably matters, but not all of the time. Well, when are some of the times? It's tough to have the conversation without specific examples, like what am I seeing when I'm now going to intervene on technique. But I think there are probably, and I say I think as in I have no data to back up this next statement, is that there are probably biological ceilings for certain tissues or positions versus others, that others may afford you the ability to more consistently layer on stress and training load without any adverse effect. And Jordan mentioned ACL, most or many ACL tears happen from 0 to 30 degrees of knee extension. So pretty much a locked knee, landing on one leg with some combination of knee abduction, tibial internal rotation, and hip internal rotation. That's just the valgus kind of umbrella term where all those sub-segments of movement. So in that case, a position seems to be more of a mechanism for injury, and I think makes a case that that position does matter just simply from a plausibility standpoint in some cases. So the question is really plausibility at the crux of it. Are there biological ceilings in some positions versus others? And I think that there probably are. I don't have a lot of data to throw there. The ACL is really the one that's coming to my mind. Now the other question is, could we have reduced the risk of you landing that way? The ACL tears in 0.04 of a second after you hit the ground. I don't know if the answer is yes. A lot of the ACL quote unquote prevention programs do have some decent outcomes, but how much is that is simply like what Jordan's saying. The athletes are just getting stronger. They're getting more fit. You are providing them with more movement solutions. They're more variable. They're better athletes. Time goes by. So maybe they just get older if these are adolescent kids and they mature a bit. So many factors at play here. So for me, technique is a performance conversation, at least as it stands right now. If you choose to have a certain technique that I think doesn't afford you the best performance, and if you don't want to change it, that's kind of your choice. But you can become sensitized to any loading pattern, as in you could look at somebody's squat and see that it's very Instagram worthy, but they could experience the same type of pain as somebody who's got the egregious looking squat who you wouldn't put on Instagram. So from just a kind of a repeated exposure, I just don't know. For weightlifting, because technique is a little bit more at play, I think the barrier to entry into the sport from a technical aspect to just get the task done is a little higher than powerlifting. It does matter from a performance perspective, but I would say that if your technique is garbage, it just limits your performance to the point where it probably is just averages out. You're not increasing your exposure to more stress because you suck at the task. And so I don't know if it would be increasing your risk unless the bar falls on your head, that type of thing, because the loads are submaximal. Your max snatch is nowhere near your max deadlift or your max squat. And even the same can be said with the clean and jerk, just to a lesser degree. So to summarize, I think there are biological ceilings. Eric, to your example of your observation of bicep tears with a supinated grip on the supinated side, we don't see bicep tears in weightlifting. I don't know. I can't think of one case I've had in the clinic that happened during an actual snatch or clean and jerk. I don't know if it matters, though, because what if we do determine that a supinated grip increases the likelihood of a bicep tear by whatever, 3%, 5%, 12%, Are you going to change because of that if a supinated grip affords you a better performance? Or are you just going to prepare as best you can? So is it the lack of preparation that is the bigger risk factor versus the position itself? I tend to err on the side of preparation, of training load versus not. And technique is basically dictated as what is the most force that I can leverage or to get the task done. That's the position that I'm going to use. We'll prepare the tissues, we'll mitigate risk with your training, with your preparation, dose response, that type of thing.
Awesome. That was an excellent answer. I thought that you guys really did a great job with that. Yeah, Jordan's wrong. You're right. No, I'm just kidding. No, like I think you guys said the same thing, so it doesn't really make any sense. Yeah.
What I was going to say real quick, because I know everyone has to go on, I'd love to continue, as I was saying before, a second part of this conversation, because I didn't even get to half of my questions. But I think what I was talking about, what Quinn kind of said when it came to the potential bicep tear, let's say, whatever, underhand grip versus hook grip, if we use an outcome-based decision model, and we're taking a look at things, and we're trying to come up with a few heuristics, and you're just as strong, let's say, double overhand as you're using a mixed grip, and even if the risk is 1 in a million, so it's not maybe, Jordan, you say statistically significant enough to even warrant a consideration, you would still probably choose then the hook grip if you know all other variables are the same and you just want to eliminate that, mitigate as much risk as possible. But to your point, Jordan, you're saying that technique isn't as important as some individuals make it out to be.
Sure. And in that particular case, I mean, again, context is important. So for a powerlifter, who, again, their goal is most weight on the bar, if they're equivalent grips, then I make less of a strong argument for exposing themselves to maybe even a slight infinitesimal increase in risk. However, for Gen Pop, I might actually feel differently, because if I can conjure a situation where they might in fact need to have be prepared to handle something with a supinated grip, then maybe some exposure and gradually increasing that load over time might be advantageous to them, just to have some sort of exposure to that. But yeah, I think that being risk averse is generally where I tend to fall on the spectrum. Like I don't want to increase people's risk to the best extent of my knowledge. But I think that's everyone here. Nobody's like, screw this person, we're gonna go.
Jordan, you've not met Shut Up and Lifters, clearly, because you live in this beautiful bubble, my man. Well, I'm gonna introduce you.
Shut Up next time. No, double supinated underhand grip, bent arm deadlifts only.
That was look. Hey, this is real. This is real. Okay. Because I'm into dropping names and causing internet controversy, just to so I can ascend the ranks.
Yes, that's
how you guys remember you guys remember the bulletproof, like you could get bulletproof shoulders, bulletproof back, bulletproof, like this was like I think Active Life RX was like the people behind this. In any event, I got sent one of their programs, and it was double underhand deadlifts. And you would work up to a set of, a reasonably challenging set of 10 and do sets across. And I remember seeing it. I go,
oh, nice volume.
What the hell is this? And I was like, and it was part of their, I think, bulletproof shoulder program. So it was like, all right, I guess I'm just gonna do this double underhand deadlift. So I just did it. I worked up to 315, I think, and I remember thinking, I was like, if I were to flex my elbows significantly and then really try to resist this decompression, due to gravity, I wonder what would happen. But I didn't say anything, because I was like, I'm not going to run this anymore. This is stupid. So then fast forward to the starting strength days. All right. So we're down in Wichita Falls, and Rip's like, hey, I'm going to make a bent over row video. You won't call it a Penlay row, RIP, but we call it a row video. And I remember this. So he starts off, he goes, so you're going to want to use a supinated grip for these heavy, heavy rows. And so he was like, yeah, we're going to work up to a near max set of 5 for a double underhand Penlay row. And I remember thinking, I'm like, now, if you're resisting that downward, the eccentric motion at all, maybe that would potentially be injurious. He subsequently made an update to that video where he was like, yeah, don't do the supinated grip. You should just use double overhand if you're going to do rows off the floor. Yeah. But I remember those two
instances. Remember that Olympia where Dorian Yates had 2 torn biceps?
Yeah, it looked great. But I remember thinking in my head, I was like, this is probably not something I'd feel comfortable taking a risk in. Although, again, I did do that double underhand grip deadlift. I'm sure people were like, is this like a secret new grip? Like, what is he doing?
Oh, yeah.
Sick gains.
I basically just heard Jordan nihilism, and it made me get excited. So I went off on a tangent here. I want to have everyone back on for another episode. I know both Jordan, Eric have to get out of here, so I'm going to ask everyone any closing remarks, any brief closing remarks. I think, like I said, a part 2 is definitely in order because that's what's fascinating. We barely scratched the surface. I'm going to start from what I can see from my perspective now with Nick, and then I'll go to Quinn, and then I'll go to Jordan.
Okay. Yeah. So, I mean, I think we all made really great points, and I just want to thank you guys for flying us all out to the Iron Culture podcast headquarters. I'm just not sure why you had to put us all in different rooms. I think we could have all sat together.
In the bathroom, Nick.
It's for the echo. We don't want multiple mics picking up the same thing.
Yeah, I got you. I know I'm just the bodybuilder, and Eric's talking about Atlas stones, and I'm trying to figure out, is that next to the hack squat machine, or is that the preacher curl? But no, yeah, it was fun, guys, and yeah, definitely be down for having part 2. It's been awesome.
Yeah, I'd love to be on again. Thank you guys for having us, and I think the listeners can understand and hopefully appreciate the uncertainty in all of these things, and how we can create what we think is less wrong in the moment, but still have a caveat on a caveat with a little nuance sprinkled on top of that, and still not be really sure. And kind of, we can always then come back to square one and say, oh, just shut up and lift. So it was a fun conversation, and I would look forward to another one because I learned a lot from all you guys. So thank you.
Yep. I also had fun. Thank you guys for having me. Really enjoyed this conversation. Would love to be back on part 2. And then I think, as Quinn pointed out, it is okay to be uncertain about what we know, and then your management should reflect that, meaning that we should never be so confident in what we know unless we do know it confidently when we're actually talking about these things. And being comfortable with being uncertain is a hallmark of being educated. So we're just trying to move the needle forward here little by little, and as we all learn a little bit, we'll continue to do so.
You guys are awesome, and for that reason, I respect all 3 of you tremendously. Thank you so much for being on, and I think part 2 is definitely in order. Yeah. And I'm going to let Captain Closeout, the closeout boy, the man of outros, handle it from here. And thank you all 3 for coming on.
I know how to leave something good behind, is what you're trying to say. And Eric, I just want to say that he does it every damn time, okay? And you 3 didn't know this. You're innocent lambs brought to the slaughter. We have 3 very knowledgeable people talking about this, talking about that. I'm like, oh, like, Jordan, great point. Quinn, oh, Nick, look at all this stuff. And then Eric finds a way just to introduce that bodybuilding, natural bodybuilding, is the best discipline, where he's just like, yeah, but injury rates though. Anyways, guys, like, it's cool whatever you're saying, but like it was indirect what he was alluding to, but nonetheless quite clear. And my hat is off to you, sir, for emerging once again victorious, because this was a battle. They didn't know it. They thought they were just here for a discussion, but you killed it. I want to thank everyone for being on. I'm going to leave their links in the description on YouTube. We'll definitely have a part 2. I appreciate everyone listening to Iron Culture. I appreciate you 3 coming to the Iron Culture house, the pad, the Pimp My Ride episode. If you enjoyed this episode, you can help us out by leaving a rating and review. We're trying to raise enough money to go to Wichita Falls to stay with Rip. Last I heard, it's about $10,000 a weekend, so shit's not cheap. Help us out, and we'll see everyone in that next episode.